challenges, opportunities, and dynamics. Thank you. And thank you, Dr. Pereira, for the great talk. Thank you.
So this is kind of the same slideshow I had for yesterday, but we'll talk about things differently. SAPPHIRE is the Society of African Intervention Radiology and Endovascular Therapy. It started as a concept in 2017. We had business meetings in Cairo, connected with Meet Symposia 17 and 18, and then the first annual SAPPHIRE was in Cairo 2019, followed by 2 South Africa SAPPHIRE annual meetings, one in Johannesburg and one in Cape Town, basically before and after COVID, basically. That's the kind of that gap. And then very recently in May, we had our most successful SAPPHIRE annual meeting in Casablanca, thanks to the 2 people next to me here, Najwa and Ahmed Kamel. They did a great job. Philippe was there and supported us, along with many of our friends around the country. SAPPHIRE was also in 2025 founded legally as a foundation in the United States. Again, thanks to Ahmed Kamel through legal work, but it's now a legal entity and a foundation as a non-profit in the United States for SAPPHIRE. And that helps us with funds flow, with sponsorship from industry. SAPPHIRE, talking about IR in Africa in general, also SAPPHIRE has helped support local societies like the Nigerian Society, and helped do workshops in Ethiopia and Tanzania in 2018 and 2019. Briefly, just to overview it, it was founded in 2017, had some business meetings in 5 years, and then in 2023 it was actually formally founded. In 2025 it was legally founded, and its duality is to actually not only as a society, but it's also a board that we're working on with the help of SIR in creating a curriculum that we all agree upon as a minimal threshold curriculum for intervention radiology training. I think Fabian is going to talk about that a little bit in his talk. It is really founded, as far as what we've done in Africa so far, on the Egyptian Board of IR, which was recognized by SIR as a similar American training and similar American exam. This Egyptian board, which was founded in 2016, is very important for Egypt. It is the only one that is recognized by SIR, and SIR is refusing to recognize anybody else. It happened once, they are not going to repeat it. India has tried to do the same thing that Egypt did in 2016 and has failed. Other countries have tried, it has failed. The only one that has passed through is the Egyptian one. So I recommend that we all support it as much as we can in Egypt to support that, because that is the foundation of building other programs around the country. We're also opening to memberships. You can talk to Najwa and Ahmed Kamel about SAPPHIRE membership as well. Our aim is to get for every African country, or close to every African country, 1 IR per 1 million. That is our aim, okay? If you look at the ratio in the United States, it's about 1 to 45,000 per capita is an IR. In Egypt, it's less than 1 million. It's about 800,000 right now. You have 120 million people in Egypt, and you have about 120 to 150 IRs, okay? Nigeria and Ethiopia are kind of typical representative countries. They are large countries in Africa. In fact, Egypt, Ethiopia, and Nigeria are the 3 largest countries population-wise. And that's very typical for sub-Saharan Africa to be in that range of 10 to 40 million 1 IR to every 10 to 40 million. So we need to reach that target of 1 to 1 million. And that is quite achievable. It's quite achievable. Think about it. 20 years ago, in 2005, there were less than 10 IRs in Egypt. Go back in time, in 2005, there were less than 10 IRs in Egypt. There's one in Alexandria, one in Munafaya, sitting there, okay? And there were like one in Mansoura, sitting there, and maybe 4 or 5 in Cairo. That was it. There were about 8 of them, okay? In 20 years, we have reached our targets, and better, 800,000. One IR to 800,000. So in 20 years, you can actually achieve this, okay? Just to show you, because general numbers, and these are not fixed numbers, these are kind of general estimates, just to show you that how many IRs depends on the socioeconomic status of the country and the development of the medicine and the technology in a particular country or a region. Okay, USA 1 IR to 45,000. Europe and the Japanese and the South Africans are probably in the 160, 180,000, a little bit less than the United States. The Europeans also have bled out a lot of IRs, especially the Brits in the last 3-4 years, going to the Gulf states. You'll see that Egypt is 1 in 800,000. Morocco and Tunisia hitting their target at 1 to 1 million. Algeria a little bit more than 1 million. South Africa, another developed country, about 1 to 1.8 million. And then you find kind of like a Turkey has about 88, 90 million people and 350 IRs. It's about one in a quarter population. And then you have kind of typical sub-Saharan Africa, Tanzania, Nigeria, and Ethiopia. Note Tanzania. Tanzania was in the 1 to 10 million, 1 to 30 million, 1 to 40 million about 7-8 years ago. It's now 1 to 7 million and will reach 1 to 1 million very soon, thanks to Fabian and Janice Newsom and their work in East Africa. Okay? So it's very achievable to get 1 to 1 million. Right now, as we stand in Egypt, we probably represent half the IRs in the continent. Half the IRs in the continent are going to be Egyptians, as we stand today. Okay, our numbers are going to, as a fraction, are going to get less as we do more progress in Africa and actually reach that target of 1 to 1 million. The challenges in Africa are considerable and very varied, but there's a common story: lack of resources, lack of education to the health system as to what IR does. One of the challenges when you're launching IR in a country is actually allowing other clinical services, medical service, to actually know what IR does and what IR can offer. So that's one of the major challenges. In addition to consumables, in addition to the machines, sometimes it's an angiography machine problem. Usually it is not an angiography machine. It usually is consumables and inventory. The consumables are the major, bog down of IR. And it's not just having the consumable for teaching, but making sure that it's accurately delivered, that it is consistent, that's always there so they can maintain their skill set and maintain their clinical practice. That is actually the most challenging thing. When you're dealing with angiography machines, you can use, when you're starting off, C-arms, you can use cardiac caths, which are usually common, neurocaths, which are usually common in Africa, believe it or not. So you can actually use other specialties, IIs, to actually do that. One of the things that I give advice, especially to sub-Saharan Africa, is look at your power stations. Find out what power stations you have. If you have Siemens power stations, then talk to Siemens about getting a machine. If you have GE power stations, then try to get a GE machine. I learned that from the Egyptians. The Egyptians in the Ministry of Health, most of it is Siemens, because we have Siemens power plants. It was a secondary deal to the Siemens power plants that were brought into the country. So one of the hints, especially to sub-Saharan Africa when you're starting off, is look at your power plants and maybe hit on the companies to actually support you, whether it's GE or Siemens. But consumables, definitely, you have to really think outside of the box, maybe even get consumables from outside of Europe and the United States, maybe from China, even some American and European products that are actually made in China, to actually bring them from China as a cheaper bargain. Another thing is, when you teach Africans, you want them to continue to teach other Africans and not to try to keep the skill set that you've taught them to themselves. That's maybe another challenge in some places. So in general, it's multivariate. It is not just resources. It is actually your running cost inventory, and it's actually educating the referring services as to what IR actually does. Thank you.
And now Fabian Lage Go